Welcome back to part 2 of our interview with Dr. Ardelle Piper, where we continue to talk to Dr. Ardelle about all things menopause, hormone therapy, and resources that you can turn to help you manage your menopause journey. Let's dive in.
Welcome to the Girls Talk Healthy Aging podcast, where we dive deep into pressing health and fitness issues facing aging women. I'm Alli Kerr.
And I'm Shawna Kaminski. And together we'll bring candid conversations, expert advice, and personal stories that will inspire and empower you on your own wellness journey.
Go ahead.
I don't even know when they need that. How does that?
Yeah. So usually that ends up happening. Again, sometimes people will have to start to have those symptoms when they're still in perimenopause, and their symptoms start because they're getting highs and lows of their estrogen. And some people's vaginas are very sensitive to those higher fluctuations. There are some people who actually have symptoms that are kind of like this when they're breastfeeding, because when you're breastfeeding, you're not ovulating. So people who don't have a period for a year and a half after a pregnancy, they start to have symptoms that are very similar to menopause because they're not ovulating. And once they do start ovulating, their estrogen comes back and things improve, right? So this thinning of the tissue can happen starting in perimenopause. For some people, it doesn't actually happen right with their final menstrual period. Again, there's variation from person to person, variation in their activity, etc. And so for some people, they don't actually start noticing this symptom until years into their menopause. And so if they didn't have horrible hot flushes and night sweats, so that they didn't go to their doctor, even talk about their menopause, then they sometimes don't connect that problem that crops up later as being part of their menopause, right? So again, this needs to be something that we educate all women about on some sort of public forum. It needs to be something that we tell all doctors about, because they should be asking and screening for this symptom. Because when women don't know that this is something that is attached to estrogen deficiency or estrogen levels being lower, then they don't know that, tell their doctor about it. And so then they won't seek treatment. So this is something that people need to have on their radar, that in your perimenopause and definitely in your menopause, this problem can increase. And the sooner you recognize it and can start treating it, the better. Because again, the stats have been 80% of women get GSM. I'm quite certain it's higher than that.
Yeah.
I'm quite certain that a lot of these stats that we've had about how many people truly have severe hot flushes, how many people have GSM, I'm sure that the numbers are higher. And it's been a factor of the fact we haven't asked enough questions. We haven't polled enough people. We haven't let people know what menopause symptoms are, so that if you ask them, do you have menopause symptoms? If they don't know what the symptoms are, they're just going to say no, right?
Mm-hmm.
So that is a big public awareness campaign that we should have.
When do we hit perimenopause, and how do we know we're there?
Perimenopause can start happening in your late 30s. The average age for the final menstrual period is somewhere in your early 50s. We tend to quote 50, 51, but it can vary a little bit country to country, ethnicities, based on your overall, wellness, etc., your health status. So 50, 51 is the average age in the middle of the curve, but normal curve can go anywhere from 45 to 55 for you to have your final menstrual period. So that's your final menstrual period. And that isn't recognized until 12 months later, when you can look back and say, oh, it's been 12 months and I'm of the appropriate age, and I'm also having some hot flushes. Oh, this looks like it's menopause. That definition doesn't help a whole lot anymore, because whenever someone's had a hysterectomy, if they've had an endometrial ablation because of their heavy bleeding as part of their perimenopause, if they have a progestin IUD on board, if they're using a continuous birth control pill, now we can't observe people's natural cycles to just neatly, tidy say, oh, this day is your anniversary of your last period, so now you get the badge of honor of saying you're in menopause. It's not that clear cut and defined anymore. And perimenopause is what leads up to that. So perimenopause includes the entire stage before that final menstrual period, and actually technically until you've been able to see that that's your final menstrual period. So that 12-month mark after that is all included, and it starts with when your cycles start to get erratic. Again, sometimes this has kind of been seen as, oh, my PMS is getting worse, or I'm not having success getting pregnant. Your PMS is getting worse and you're not having success getting pregnant because your egg quality is going down. And so your ability to get pregnant is reducing. Your brain is trying harder to get your lower quality follicles to develop every month. And so this can actually start presenting as higher estrogen levels, which can mean worse PMS, heavier periods, more headaches, more mood problems, and actually shortened cycles where your periods were before, if they were 30 days apart, now all of a sudden they seem to be 25 days apart. That is your earliest sign sometimes of your perimenopause. And so we haven't been talking about that until very recently, that is your first sign. It's not when you start dropping periods. When you're dropping periods, you're actually getting to the point where you can have months where there isn't an egg that will rise to the occasion and ovulate. We now call that late perimenopause. When you've gotten to the point where you've dropped a couple periods in a row, you've had maybe 3 months with no period, we know that you're getting close to your final menstrual period. So all of that time before is your early perimenopause, and it manifests in many different ways. It can be mood problems, it can be worse periods, it can be vaginal dryness. These symptoms can come and go. They might not be there in your first 2 weeks when you're making lots of estrogen. They might be worse as part of your luteal phase, your PMS phase, and then they go away again, right? So perimenopause, I think is going to be, well, it is now. It is now kind of the new area that we really need to talk about more.
And what do we do when we're in that phase? Are there things that we need to be thinking about, steps we need to be taking?
Yeah. So observing your symptoms is important, right? Again, a lot of people just kind of cruised through their menstrual cycles and really not thought about them, not maybe track them. If you've had horrible periods or endometriosis, sometimes you've already been tracking your periods and your symptoms, right? So step number one is start observing your own body, right? Start learning about what your body is doing. So this is where I like to encourage people to use a symptom tracker or a cycle tracker. Start writing down when you're having the first day of when you're bleeding. Start writing down, like I've created one that's an Excel sheet with different colored, bubbles, use felt markers or crayons or whatever, and print off a piece of paper that has an Excel sheet that's 12 by 31, right? That gives you all the months and all the days of the year on one piece of paper. And start using different colored dots to say, when are you bleeding? When are you spotting? When are you having headaches? When are you having horrible mood? When are your breasts tender? Start mapping it out so that you can start noticing your own pattern. And that actually becomes a tool that you can share with your practitioner as well. So start observing your own self. Start looking at the way other things in your life are impacting on that, right? It's okay to acknowledge that maybe we need to improve our nutrition. Maybe we need to take this as an opportunity to develop more predictable self-care, to be increasing our wellness overall with better exercise, with better sleep patterns, with doing some of these things that, bring up our resilience and our health on a ground level basis, so that when these symptoms come, we have some tools to help us with it. If your symptoms of perimenopause are horrible, then, and again, we shouldn't wait till they're horrible, right? You can talk to, we should be able to have people come to a healthcare practitioner and talk about solutions. So if your bleeding is heavy, well, then we should be asking people about that so that we can identify if you have iron deficiency anemia. We should be offering solutions like the progestin IUDs or the endometrial ablations and such to reduce the amount of blood that you're losing every month. Because being anemic is not helping your fatigue. It's not helping your energy. It's not helping anything. So, looking for kind of those low-hanging fruit of how can we just help the worst symptoms. If people are really suffering in their perimenopause, then we should do as well a risk assessment to say, are you a good person to consider a birth control pill, even if you haven't been on one before in the past? Because and again, I use the term birth control pill to include the ring that goes in your vagina, the patch that sticks to your skin, any of those combined contraceptive options. When you use them as contraception, they are telling your ovaries to stop ovulating. That's how you don't get pregnant from them. In perimenopause, that can be very therapeutic to say, these ovaries are causing a whole lot of problems. Let's tell them to take a back seat. And I know that sometimes, there's been a lot of, oh my gosh, well, this is going to be funny when you actually show the video of this. There are a lot of people who like to now badmouth the pill as being so unnatural and like so excessive and being such, synthetic hormones. They're so bad for women. They have a therapeutic benefit. It's been very good for women to be able to have control over pregnancy and have options. And for some people, the birth control pill is the best for that. And for some people in perimenopause, it's their best option because hormone therapy is a drop in the bucket compared to what they're doing. So, all of those can be things that are part of the toolbox of how to manage perimenopause.
I think creating awareness that, going through your 40s or even late 30s, that women need to be aware, because so many of the women that I talk to are, in their 50s, and they're saying, well, I think I'm having menopause symptoms. And I often will say, you've probably been having these for a very long time.
Yeah.
And you didn't know it. And that is part of the problem as well, is that many of the symptoms, women don't even understand that
No.
estrogen is in every tissue of the body. And so every system could be related.
Yes.
And
Yes.
that
And it doesn't help when young people are actually recognizing that they have symptoms and go to a healthcare practitioner and they're told, oh, no, you're too young to be going through menopause. Well, you're probably not too young to be going through perimenopause. And again, the numbers in here. Average age being 41. So normal in most populations being 45 to 55. Early menopause is between 40 and 45. Premature menopause is under the age of 40. And that includes, premature ovarian insufficiency, people who've had their ovaries removed with surgery, or medically are in menopause, like say maybe because of breast cancer and such. So even when you're looking at just the statistics of average age of menopause, someone who's going to fall into that category of normal, having their final menstrual period at 46, if perimenopause symptoms can precede that by many years, then you can be having perimenopause symptoms easily in your late 30s and still be considered in that class of normal. So all those people who are also potentially having early menopause or premature menopause, we can't just brush those people off. Because if you truly are having menopausal symptoms in your 20s or 30s as part of premature ovarian insufficiency, we cannot miss that, because there is a health concern for people. And not only that, but like the trauma of not having that recognized. And then you decide that you want to try to get pregnant and such. And now you're told, oh, you actually have premature ovarian insufficiency. And that's interpreted as menopause, right? Like that's horribly traumatic for people in their 20s and 30s to find that out. So, we can't just brush off people's symptoms and just say, oh, no, you're too young. Because even premature ovarian insufficiency is 1% of the population. So that still is 1% of people can legitimately be having menopause symptoms when they're nowhere near 50.
So you've provided such great information in this podcast. What other books or resources would you recommend that women turn to so that they can go to their physicians? Because if we go en masse, then we will start a revolution in terms of if the medical community doesn't pick up on this, our demands are going to force more doctors to become educated. So where do we start?
I think it really helps if we realize that this is a problem we all need to solve together, right? It's very frustrating for the general population because they want to feel like this is their doctor's job, is to know this and to help them, right? And so it can be a very frustrating and controversial thing to suggest that women need to actually educate their doctors. But the truth is that kind of is the situation that we're in right now. So eventually, hopefully, we're not going to be still in that situation, right? But right now, we are in a very awkward gray zone where this need has been acknowledged, but the knowledge for physicians isn't out there. And trust me, there are many physicians who are now realizing that this is education they did not receive. But we also know that right now in Canada and probably other places in the world, thanks to pandemic and burnout, and let's face it, our physician community is very female dominated. We have more female physicians than we have ever had before. And it's because women are great at medicine, right? Women are compassionate. There's lots of great data that it's about women surgeons having, less complication rates, about women physicians doing such a great job of chronic health management. But then these are also women who themselves weren't taught about menopause. So they themselves might have been going through perimenopause and menopause without anyone appreciating that their exhaustion, their anxiety, their overwhelm might also have something to do with their own health. So they're not recognizing it in themselves. They're not recognizing it in their clients. They're overwhelmed, even more so now because we've had so many doctors leave the profession. So now the doctors that we do have are overwhelmed with even bigger caseloads. So the reality is that there is only so much time in the day, and this is a very important need for them to pick up, but they're just pulled in so many directions and they're already spread so thin, right? So it really does help if we have a philosophy of allyship, right? To say, look, I'm going to give my doctor the benefit of the doubt that they are struggling with this too, right? So you can go to places like the Australasian Menopause Society. They have a huge database of evidence-based handouts that are, some of them are called information sheets. They're resources that are free and open. There's some of them are categorized for physicians. Many are categorized under like for patients. There's just a search bar there where you can just search. You can just type in, bone health, weight, vulva, vagina. Like you can type in any sort of keyword and they'll pop up articles and information sheets that have been published on that. The information sheets themselves are concise. They are evidence-based. They have the references at the end. They have the date at which they've been updated. They have the Australasian Menopause Society banner across the top. This is a reliable document that if you come into your doctor with this and say, I've been doing some reading, because there's a lot of garbage out there on Google, right? And so if you come in and you say, well, I've been doing research on Google, there's a lot of doctors that it just gets so frustrating, because then you kind of start prepping yourself for, okay, what disinformation am I going to have to now address, right? But if instead you come in and you say, I've been having what I think are perimenopause or menopausal symptoms, I found this great handout from the Australasian Menopause Society. There are also handouts in fewer number from the North American Menopause Society. They've now been renamed to the Menopause Society, but you can still find them the same way. British Menopause Society. There are a few handouts, not quite as many, on the Canadian Menopause Society. Go to the society websites, because yes, there's a lot of chatter out there about, testosterone, this, that, but the meat and bones of what you need for menopausal therapy, as in the guidance that hormone therapy for low risk women is safe and effective, the guidance that virtually every woman can be offered local therapy, those things are very clear on the society websites. They are clear in the CMAJ article that was published. They're clear in the guidelines from all the societies around the world. They are very clearly outlined in those information sheets that are 2-3 pages that you take into your doctor and you say here, right? So I think that has the potential of really like exponentially improving the way we manage this on the whole. Yeah.
That is fantastic information. And I do believe that some doctors will register themselves within those societies.
Yes.
If I'm not mistaken, can you speak to that?
So again, this kind of speaks to the fact that menopause has sort of been the underdog, right? So the North American Menopause Society has had a test that they've given to give you a certification of sorts. Well, anyone can study that textbook that they create, or with their own, clinical practice and their own research that they've done, they can write the exam. They've been typically they've been always provided at any of the Menopause Society meetings. It's usually the first day or two that they do a quick little course and then they write the exam. So that gives you a certification. Unfortunately, though, there are still people who have had that certification and they're still providing compounding and promoting things that are not evidence-based, right? So, that certification is there, but it's not necessarily, it's not like they get kicked out of the Menopause Society if it is found out that they are compounding. The Menopause Society has very strong statements against custom compounding and pellet therapy and such, but yet there are people who have a NAM certification who do provide that, right? So this is a problem. This is a problem. But it does mean that, yes, people can be part of the Canadian Menopause Society. Again, how much, societies always, memberships cost money. They're supposed to have benefits associated with them of, like, say, discounts if you come to meetings and such. We don't need everybody to become part of the Canadian Menopause Society in order to do better menopause. It helps because more people who are members will then bring more money into those societies so that they can continue to do research and then have the funds to create, documents and guidelines and infographics and whatever else. Those societies are meant to be nonprofit organizations that can help with that. So the more people sign up and become members of societies, the better. Okay. And then there's other societies. So say the British Menopause Society, or the International Menopause Society out of Europe, Australasian. Anyone can decide that they're going to pay membership and be part of those societies, and then get their journals and get the inside track to things, and be part of webinars and such, and learn. So that evidence-based community is really important, that we have more people enrolling and coming to those meetings, so that you can talk and listen and talk with your colleagues, and describe clinical situations that you've been in, that you can learn. Being a physician, being a nurse practitioner, anyone who's in the healthcare industry, this is a lifelong learning process. There are definitely things, even as a menopause specialist, that I say and do differently now than I did, for sure, 10 years ago when I graduated or finished my program. And there are many things I do very differently than 5 years ago and 2 years ago. I'm constantly changing the way I phrase things, the way the comfort level I have. I finished my program in menopause fellowship, where we were still trying to convince all women at the age of 60 to come off of their hormone therapy, because we were still dealing with the ripples of the WHI. If you're older, hormone therapy is a greater risk. We've changed that. Right. So I would love if I could call up all those people who, a few years ago, I tried to convince them to come off of their hormone therapy, and say, we have better evidence now. Right. And so part of the nature of this is that it is constantly moving. And yeah, unfortunately, sometimes we are telling people or doing things that a year later, a different study comes out that reassures us we can do something else in a different way. So this is part of that really important feature of the evidence base, of the academia, of us doing more research, of us following guidelines and such, because it is moving fast.
So how does one know that they have a great doctor that's up on the latest research? Because like, we would all love for you to be our doctor, Ardelle, but that's not possible. So how do we know that we're under the care of a competent doctor?
Yeah. Well, hopefully all doctors are, generally competent. How much are they competent when it comes to menopause, right? That's been the problem that we've been discussing today. But if you come in with evidence-based information sheets and such, or you read a really good book, like we mentioned the societies and those quick, easy PDF handouts that you can print off. There are also really good evidence-based books that are written by doctors, like Dr. Anise Mukherjee. Her Complete Guide to Menopause. I recommend that one all the time. I have a huge list of books, that I could list. There's two from the UK that have written the Complete Guide to POI and Early Menopause, because those women should really not be scared of hormone therapy or think about the risk as much as older women should, because they're younger, they need the replacement. There's one by Dr. Eliza Royden, that's the Complete Guide to Breast Cancer. These are books that are written by physicians that may be a bit heavy in their reading, but they're thorough and they are evidence-based. And again, your doctor might not have read those, but if you come in with those little small handouts, then again, your doctor, hopefully, even if they don't have that knowledge base, is an empathetic person and really does want to work with you and help to improve your health. And so if you come in with a good evidence base, and hopefully, like, you have to be living under a rock even as a doctor, even though we're all busy. There's been so much menopause on every, in every magazine, on the news, on there, that virtually every physician by now has to have heard that menopause is something that is picking up speed. So if you come in with that sense of allyship, even if they don't have that evidence base, they can still potentially partner with you. And that's where, menopause specialists, I think that the niche is changing. Like, where before I used to see people and prescribe them hormone therapy, and I kept them all to continue seeing them every year and do their refills, because their doctor wasn't going to do it. They thought it was dangerous and this needed to be handled by a specialist because this is such a high risk area. Now this is changing fast. This is why I have a telemedicine practice, is because there are a lot of doctors who are like acknowledging that they don't know how to do the risk assessment. They don't know how to counsel. They don't know how to answer people's questions and fears about breast cancer, about this, that, but they're happy to refer to me for me to do that. And for me to reassure people, answer their questions, suggest what they should be on hormone therapy, make it down into a short list, come to some conclusions, and then I hand them back, right? So for me, this has been a real big change. And I really like it. I feel like this is a really good use for me now as a specialist, to fill in that gap where primary care practitioners don't yet have the knowledge. And so even if your physician is not a menopause specialist, that doesn't mean that you can't have a good relationship with them and be honest and learn and help them learn as well. Because if the two of you have a good relationship and can learn a bit about this, that is going to help them with the next woman that's in the waiting room after you, right? So this really does have a huge ripple effect.
If you had a wish for our listeners, Ardelle, what would it be?
Vaginal estrogen. If we could really get everybody onto the local products, and there's quite a few of them now to choose from. I say vaginal estrogen because that's been the classic, right? But there are creams and tablets and the ring that contain estrogen for your local product. There is the capsule that now has DHEA, and there actually is now even an oral tablet that isn't estrogen itself. It's called a SERM. It's a selective estrogen receptor modulator. So you can't take it if you're on systemic hormone therapy because it'll compete for the receptors, elsewhere in your body. But if you're on nothing else, this is an oral tablet that you can take, and it actually is beneficial to your vaginal tissues. It is beneficial to your bone tissues. It does not stimulate your breasts. It does not stimulate your uterus. It's one of these. This is why we actually want, quote unquote, synthetic hormone therapies, because some of these are brilliant, right? Some of these SERMs are brilliant in the way that they can target things and actually reduce breast stimulation and not require progestins, etc. So this one oral tablet is classified now as a therapy for GSM. It's Health Canada approved for that in Canada. And so if everyone could understand about their vulvar, bladder, vaginal health and learn about the best moisturizers and lubricants, learn about what good satisfying sex is, and that there's nothing about you that's broken if you're not wanting unsatisfying intimacy, and that they could understand the role of how using the right vaginal products can really help with that. That's what I would do all day long if I could.
Well, my wish is that more education and there's more physicians like you out there, Ardelle, because I think that is what we really need, for women to be educated, for their physicians to be educated, and we would have quality of life, a bigger quality of life in general.
It's happening, right? I'm seeing it happen, right? And like, I choose to not be a doomsdayer of, like, I went through my frustration with this too, of being like, how could we have done such a bad job? How could we have missed the boat? And now I'm like, you know what? This is huge opportunity. And unfortunately, so many women, are struggling with the symptoms, and it's been a huge disaster of the medical community that women have had to suffer through this before we actually get it right. But we can get it right now, right? And so there is a potential for there to be lots of doctors who can take up the torch and who can do a better job. And that's why I love, going on the road and doing menopause talks and like the people, like, anytime someone asks me if I will do a lunch talk or a dinner talk, or I will do it. I will do it, because if I can educate 10, 20, 100 people in a sitting, then that is accomplishing what you're wanting, right? That is accomplishing, Shawna, what you're saying, and what you, Alli, really want, is that we can get a better appreciation and strategy to address menopause in the greater healthcare community as a whole. And it's happening now. And I've decided to, stop being negative about how badly we've been doing this, and instead start to be excited about how fast and how quickly it's getting better and how much potential there is.
Thanks for listening. You'll find me, Alli, on Instagram at Alli Kerr Fitness.
And you'll find me, Shawna, on Instagram at Shawna Kaminski. Feel free to pop us a DM with questions and or feedback. If you're enjoying the Girls Talk Healthy Aging podcast, please subscribe and share it with other health-minded women. Ratings and reviews are also much appreciated and help us get our message out to a larger audience.
Until next time, be healthy and be happy.